Hi, my name is Milkie and I am an assistant professor in the Department of Preventive Medicine at the Feinberg School of Medicine, Northwestern University. My research leveraged community engagement and implementation science to promote health and well-being for minoritized and underserved population, focusing in particular on cancer prevention among Asian Americans. Disclosure, I have received an honorarium from the Vietnamese Association of Illinois, and I have no other conflict of interest to disclose. So the focus of my presentation today is on HPV vaccination among Asian Americans. And at around 22 million, Asian Americans are the fastest growing racial or ethnic group in the US today. They are extremely heterogeneous and comprise of people from over 30 states or countries speaking over 100 languages and dialects. Different origin groups have diverse immigration histories, cultural backgrounds, and patterns of health service utilization. I've done research on Asian American health for close to a decade now. And one of the things I found to be pretty challenging in my work is what we often call the model minority myth. Now, in a nutshell, is this pervasive idea in certain corners that Asian Americans are a monolithic entity. They're all the same no matter which origin groups, and Asian Americans are all experiencing socioeconomic success and little disadvantage or health disparities created by structural racism. Now, these are myths, and they don't reflect the reality or diversity of experiences of different Asian origin groups. Unfortunately, one of the direct consequences of the model minority myth is that this leads to critical data gaps in reporting of health outcomes for Asian Americans. Too often, different Asian origin groups are combined under one single category, and data are not reported separately for different origin groups. Now, I want to give an example that reflects some of the heterogeneity among Asian Americans that is relevant to our conversation about HPV vaccination. This table is from a paper that reports cancer incidence rates for the 6 largest Asian origin groups: Chinese, Filipino, Japanese, Korean, South Asian, and Vietnamese. I've highlighted the last row, which contains data specifically for cervical cancer. And what you'll see here is that if you're looking at the cervical cancer rate for Asian as a whole, then it's 6.5 over 100,000 person years, which is lower than that of non-Hispanic white, at 7.5. However, if you look at specific origin groups, you would actually see a pretty wide range. So South Asian at 4.6, Filipino at 6.3, and Vietnamese American actually have higher rates than non-Hispanic white at 7.7. So this shows the need to have disaggregated data by origin groups, as opposed to lumping all Asian origin groups together under one category. So many of us working in the HPV vaccination research field are familiar with the National Immunization Survey, or NIS-TEEN, conducted annually by the CDC. And I want to acknowledge that the NIS-TEEN data are really useful in many ways. I've analyzed them and used them in publications. But unfortunately, one of the things that NIS-TEEN does not do is providing public use data or reporting by Asian origin group. Now, NIS-TEEN collects data on origins of respondents, so they do include questions on whether you identify as Vietnamese, Chinese, Korean, etc. But they do not provide this information in their public reporting of the survey results. So for researchers like me who are interested in getting disaggregated data, unfortunately, what we get is just data for non-Hispanic Asian adolescents as a whole. It's somewhat informative, but much of it is still a black box. And with the prior example, I've shown that there are heterogeneity in rates of HPV-related cancer, and that lumping all Asian origin groups together is not helpful for understanding between group differences. Instead, what we really need is data disaggregation to identify the populations facing highest risk of HPV-related cancers or HPV vaccine underutilization. And now I would like to highlight some recent work in this area that do use national representative surveys and report disaggregated data. So this is a recently published paper in JNCI Cancer Spectrum that examines cancer incidence and trends for 6 cancer sites that are commonly associated with HPV by disaggregated Asian American, Native Hawaiian, and other Pacific Islander ethnicity. It uses the Surveillance Epidemiology and End Results, or SEER database from 1990 to 2014. One of the key interesting findings is the variability of HPV-associated cancer incidence when you disaggregate the data. So here you can see that among women, HPV-associated cancer incidence range from 6.3 to 22.8 per 100,000, and disproportionately affects Southeast Asian groups such as Cambodian, Laotian, Vietnamese, as well as Native Hawaiian and Pacific Islanders. Among men, you see less variation compared to women, but still worth noting that Native Hawaiian men and Cambodian men have much higher incidence of HPV-related cancers compared to other groups. And now this is another paper that came out very recently. The paper used the data from National Health Interview Survey from 2015 to 2018 and reports on HPV vaccination data for adults, and specifically comparing Chinese, Filipino, and Asian Indian adults to non-Hispanic white adults. What they found was that overall, there is variation in HPV vaccination rates across Asian origin groups, with Asian Indian adults having the lowest HPV vaccination rate, 23.2%, and this is significantly lower than that of non-Hispanic white at 35.6%. Now, the researchers further analyzed the data by both origin group and nativity, so whether the respondents were born in the US or outside the US, and they found that the lowest HPV vaccination rates were observed among foreign-born Asian Indian adults at only 12.7%, and foreign-born Chinese adults at 25.3%. And again, you see that these rates are lower than those among non-Hispanic white counterparts. So having established the needs for disaggregation of data to identify origin groups at highest risk, now I want to talk a little bit about another study that I did on facilitators of and barriers to HPV vaccination in Asian American communities. So when I started out in this field, there was just a lot of unknown. And so I want to do a systematic review of all literature that exists on this topic and ask what are the different determinants of HPV vaccination among Asian Americans. This work was done in late 2019, so about 3 years ago, and we did a search on PubMed and several different databases. We found a total of 26 studies that have examined determinants of HPV vaccination among Asian Americans. The origin groups that were most commonly studied were Koreans, Chinese, and Cambodians. Now, a few studies also focus on other origin groups such as South Asians, Vietnamese, Hmong, Filipino, or Japanese. About half of the studies capture perspectives of caregivers or parents on adolescent HPV vaccination. And several studies also focus on college students and adults. There is a wide range of reported HPV vaccine initiation and completion rates across studies, with report initiation ranging from 14 to 67% and completion from 9 to 63%. A few studies capture the impact of health system or practice level determinants, particularly with the availability of language service or insurance policy. And at the provider level, most studies focus on recommendation from the providers or discussion with providers about HPV vaccination. These are some of the most common individual or patient level determinants across the 26 studies. The most common ones include vaccine knowledge or awareness, perceived safety, perceived susceptibility to HPV, beliefs about the link between HPV vaccination and sexual activity, perceived effectiveness, perceived cost, motivation to get protection from disease, and influence from family members such as mothers. English proficiency of the respondents was also documented in 3 studies as being associated with HPV vaccine intention and uptake. And all in all, what I hope to do with this paper is to provide a comprehensive review of determinants that can be used in designing interventions to address HPV vaccination in Asian American communities. Now, knowing that there exist these disparities in HPV-related cancers and HPV vaccination, and knowing some of the determinants of HPV vaccination among Asian Americans, for the last part of the presentation today, I want to shift to discussing some of the current developments in strategies to increase HPV vaccination for these populations. Now, there are best practices that have been developed and centered around what clinics or health systems can do to boost HPV vaccination. And these practices are really important because ultimately much of HPV vaccination is still happening inside the clinic or the health system. And what I want to emphasize is a complementary approach in addition to these clinic-based best practices. So specifically, what can we do with community outreach to help individuals become more aware of the vaccine, know more about it, and increase community demand for it? And here is one of the rationale for why we should do community outreach on top of clinic-based practices. It's based on some of the formative work that I have done with Vietnamese Americans and their perceptions of the HPV vaccine. Now, Vietnamese in the US is a population that is at high risk for cervical cancer. And they also have low knowledge of the HPV vaccine when compared to other Asian origin groups and to non-Hispanic white. In my interviews with Vietnamese mothers in the US who had an adolescent who's eligible for the HPV vaccine, some mothers talk about how they did not agree to the HPV vaccine right away when the providers recommend it. So for example, here a mother said, "I made the decision a few months later. It was partly because I needed to think and partly because I was busy. I could not make the appointment with the doctor. That's why my oldest child got vaccinated when she was 16. Another comment, when the doctor recommended the HPV vaccine for the first time, I did not let my son get the vaccine right away. I told the doctor that I would learn more about the vaccine. The following year, I let my son get the vaccine. So these realities point to the need for culturally relevant health education around HPV vaccination that parents or caregivers and others can access prior to the clinic visit because there are barriers to digesting interventional materials when presented during brief encounters with providers. Now, these are some of the recent examples of research that are developing solutions leveraging digital health for community outreach. It's very encouraging and interesting to see the work being done in this space. So as you can see here, there's a study that has built a storytelling intervention around HPV vaccination using a mobile web-based platform for Korean American college students. Another one uses the group chat function facilitated by a lay health worker to encourage family discussions around HPV vaccination and cancer screening for Vietnamese families. And the third is the development of a narrative intervention targeting HPV vaccine behaviors among Khmer mothers and daughters. Now, most of these studies are pilot studies with small samples, but they are positive preliminary outcomes and show potentials. I also want to briefly talk about my current work addressing HPV vaccination among Asian Americans in Chicago. I am working with partner organizations in Uptown, which is an area that has a high concentration of Asian residents, especially those who are foreign-born. We actually just got a small grant to co-design culturally relevant strategies with the community partners, and the plan is to leverage existing programs and resources in the community and identifying HPV vaccination champions that can help us increase community demand. So I'd like to talk about some of the recommendations for research, practice, and policy to increase HPV vaccination among Asian Americans. Now, going back to what we discussed earlier with the data gap, public health surveillance systems should both collect and report disaggregated data for different origin groups. There are some movements at the federal level in recent years, especially to acknowledge the diversity of Asian Americans and support for disaggregation of data. The Biden-Harris administration established the White House Initiative on Asian Americans, Native Hawaiian, and Pacific Islanders, and they have developed national strategies focusing on expanding the collection and use of disaggregated data at the federal, state, and local level. And they also focus on strategies for improving health outcomes, eliminating disparities, and expanding access for these communities. In addition to improvements in the collection and reporting of data by public health systems, I think that with health providers and systems, there's a need to understand the heterogeneity in HPV vaccination knowledge and uptake for different Asian origin groups. And in addition, they should also take into account how cultural beliefs and contexts, immigration status, English language proficiency, or other sociocultural factors can influence vaccine knowledge, confidence, intention, and uptake in these populations. And finally, going back to the point about community outreach, and again, we're thinking about the diversity of this population. This is a place where one-size-fits-all interventions might have limited utility. And instead, what we really want is partnership with trusted community agencies and messengers, including community-based organizations of social services, to deliver culturally tailored, linguistic appropriate interventions that also leverage digital health technologies when appropriate, so that we can ensure we can reach a large number of people. I would like to acknowledge my community partners, the Center for Pan-Asian Community Services, BPSOS Atlanta, and Chinese Mutual Aid Association in Chicago, as well as my funder, the National Cancer Institute, for the research present in this study. Thank you, and please contact me if you have any questions.